Now I'll start my presentation, Dr. Saloni Gupta. Basically, we are here to present clinical techniques for basic new postgraduates for corneal examination and for cracking the refractive code. We all know that the most important modality for examining cornea is proper slit lamp examination. After making a basic suspicion, we can go on to corneal topography, specular microscopy, anterior segment OCT, confocal microscopy, etc. Slit lamp, we can use various illumination techniques, and all mastering all these illumination techniques is very important for a detailed corneal examination. Like diffuse is used for any gross abnormality and contact lens fitting. Optical section is very important for delineating the various corneal layers. The dystrophy deposition is at width layer, corneal foreign body, corneal curvature, thinning. Indirect is important for corneal microcyst. Retroillumination is especially useful for endothelial deposits and epithelium vacuoles. Specular is best for any endothelial dystrophy, and sclerotic scatter helps to localize a very faint, subtle corneal irregularities. Specular microscopy is basically used to diagnose pathological changes in endothelial disease. It is used in eye banking for assessment of donor cornea and for pre-op endothelial health survey. This is a normal specular microscope. We have to see basically the cell density, which should be more than the age appropriate number, more than 2500 for a young person. The 6A hexagonality, which should be more than 50%, and the coefficient of variation, which should be less than 33%. This is a case of endothelial dystrophy with the decreased coefficient of variation and increased 6A and cell density. It is useful in conditions like Fuchs, PPMD, iatrogenic corneal endotheliopathy, and post-penetrating keratoplasties. Anterior segment OCT is also an important tool for defining the various layers of the cornea. It's especially helpful in keratoconus, even in hydrops case, to see the edema. For corneal dystrophies, to see the layer of deposition. It helps in monitoring the progression of infectious keratitis and the management effect. It is very useful in DMD to localize it, to classify it, and then to treat it. It is also useful for anterior segment surgeries, like planning of preoperatively DALC, DSEC, DMEC, and also intraoperatively in the form of AIOCTs. Like this is a picture of keratoconus with acute hydrops, and this is showing deposition in anterior stroma in early granular dystrophies. Now, another important tool for postgraduates is corneal topography. It can be based on Placido disc-based, slit scanning technique, and Scheimpflug. The most commonly used is the pentagram. The printout comes as a map of phone known as the quad maps. It has the patient details, it has the keratometric values, pachymetry values. The first map is a very important map, the axial or the curvature map. It represents the anterior curvature of the cornea and represented in the form of dioptric values. The average dioptric value is 43 to 46 diopters. Anything more than 47, 47.2 to be exact, is considered to be suspicious for ectasia. The warmer colors represent the higher dioptric values or the steepening and are at risk. Next are the elevation maps, the anterior and the posterior elevation of the float maps. This is when we compare the anterior and the posterior curvatures with a reference or a best fit sphere, and anything more than 15 micron in an anterior and more than 20 micron in a posterior is suspicious for an ectasia. Then last is very important is the thickness map. It tells the thickness of individual points of the cornea, and the thinnest point should be at least 470 micron to prevent any form of ectasia in the future. This is a bad map. This is especially important for any keratoconus borderline cases because it compares the reference cornea with the enhanced best fit sphere, and here also the warmer colors represent that there is a risk of keratoconus or any other form of ectasias. In keratoconus, we have to basically look for 3 points: the increase in the area of corneal power more than 47.2, inferior superior asymmetry more than 1.4, and skewing of the axis more than 22 degree. Like we can see a asymmetric bow tie here, suggestive of keratoconus. It's mostly seen in axial curvature map. And in this we can see a crab claw foot in a PMD case. Now, after all this, this is very important for planning any refractive surgery. We'll learn a basic about how to pre-operatively decide which patient is fit for refractive surgery and which is not. Refractive surgery can be cornea-based procedures or the lens-based procedure. Here we will mainly be discussing on the corneal-based procedures. The FDA-approved range for various refractive procedures are the following: LASIK minus 10 diopters to plus 4 diopters. Smile is minus 10 and up to 3 diopters of cylinder can be corrected. However, the range can be increased if we are using a lens-based procedure. After a proper consent and a proper history, we have to calculate the BCVA with cycloplegic refraction. The PMT and the POG shouldn't differentiate more than 0.5. There should be a stable refraction for 1 year. We have to measure the pupil size, intraocular pressure, anterior segment, posterior segment for any lattice holes, proper TFL assessment. And now to find out if the patient is fit for corneal-based refractive surgery, most important are the investigations. 4 parameters are very important. First, we have to see that Kmax should be less than 47 diopters. CCT or the thinnest point thickness should be at least more than 480 microns. We have to calculate the RSBT or the residual stromal bed thickness that we calculate by subtracting the flap thickness and the depth ablation from the central corneal thickness. The flap thickness usually varies from surgeon to surgeon and can be 90 to 120 micron. And the RSBT should be at least 250 or preferably 300 microns for performing any corneal based procedure. Percentage of tissue ablation is altered is also calculated, which should be less than 40% for any risk-free corneal-based refractive procedure. It is calculated by flap thickness plus ablation depth divided by central corneal thickness. After calculating all these scores, we can calculate the Rendelman ectasia score. The higher the score, the more the chance of ectasia and more the patient is unfit for carrying out any cornea-based refractive procedure. As we have already discussed, beside all the calculations, corneal topography should be within the normal range for any corneal-based procedures. If it any suspect, we should wait, give a time of 3 to 6 months and then follow up the patient. Bad map is very important. All the 4 quad maps are important. Besides the corneal topography, corneal biomechanics is also very important. We'll come to that. If there is any at-risk corneas, we should always defer the surgery or plan the patient for a lens-based procedure. Corneal biomechanics is very important in the form of CBI and TBI, Corvis Biomechanical Index or TBI. These should lie in the green zone so that the corneal biomechanics is maintained even after post-corneal based refractive surgery. If all these factors come into within the normal limits, like age of the patient is more than 18 years, there is a stable refraction, no ocular systemic contraindications, all the parameters like CCT is more than 480 micron, RSBT more than 250 to 300 microns, PTA less than 40%, no indication of any form of ectasias, posterior elevation less than 15, bad map is normal, then we can proceed to the surface ablation techniques, LASIK or small, any corneal based procedures. LASIK is suitable for most cases and cylinder is suitable for moderate powers. However, if they are not suitable, then we have to proceed for the lens based procedures or the phakic IOLs.